to welcome you to the Parkinson's Disease Community Education Day. And we know that there are a lot of new people here, and I thought we'd get a show of hands to see who's been here before, who's ever been to this meeting before. Good. And who's the first time? Oh, wow. Very good. Well, we are so glad all of you are here and have come back. We have almost 300 people here today, which is absolutely a record. So please give yourself a hand. I'm Kathy Morton, and I'm president of the Richmond Metro Chapter of the American Parkinson's Disease Association here in Richmond. And I wanted to say thank you to the planning team. Last year, after the conference in November, we started right away with planning for today. So it is a year-long process, and of course, you know, it takes a wonderful team. And I want to share with you the team that I work with. You've heard Miriam Hirsch this morning. Miriam, would you raise your hand? Miriam was teaching the Parkinson's 101. We have Lynn Clanchard. Where's Lynn? In the back in orange. Susan Dietrich from Charlottesville. And Andrea Persigan. And Andrea, where's Andrea? Right back there with her table. She's from VCU, so she has joined us. She is working with Dr. Bennett now, and so she's joined this planning team, so we're happy to have her with us. Thank you. Wanted to tell you a little bit of housekeeping duties. We have bathrooms. If you go back out to the lobby, there's some steps there, and there's bathrooms, and then up further, because when you have 300 people, we need lots of bathrooms, I know. And then up the ramp there are also bathrooms. We'll be eating lunch in here at 12. So when we finish with the speaker this morning, then if you want to get up, move around so that the folks from the Holiday Inn can come in and get the table set and the food, then we would appreciate that. We have a raffle. If you will see the young lady, which is Miriam Hirsch's daughter, Eve, and she's got a raffle, and that is for prizes. We're going to draw those at lunch. So if you want to get your raffle ticket when we take the lunch break, we're going to do that about 12:45. And there's one ticket is $1, and there's 6 for $5. I hope everybody has picked up a packet. The packet is information for you today. On the left-hand side, you will see the agenda and how we're going to do things and sponsors. But important is the evaluation form in this package. So I would hope that you would do that. This helps with planning for next year's conference. So if you will take time to do that, sometimes it's just easier to do it after each speaker. So we would ask that you do that and leave it on your table at the end of the day, or you can drop it off in the lobby. Also wanted to tell you about a fundraising opportunity that we are looking into. We are thrilled to have Denise Barker. Where's Denise in the crowd? She's got her hand up. She's got black and white on. But Denise is agreed to lead this fundraising for the chapter and for the support group here in Richmond. So we are going to be doing a cookbook. And I know there's great cooks in this audience. And I don't know all of you, but I know there are great cooks. In your packet, there is a form that looks similar to this. It's a 2-page form, and it's asking you to give us your favorite recipes. On the second page is the form that we ask that you fill out and give us your recipes. If you have one that you make all the time and you want to leave it today, there's a basket out back on the table, and if you want to drop it in there, that's fine. If not, you can mail it to us or you can email it to us, and all that information is on the packet. But I want to thank Denise for taking this and running with it. She has done this with her church, and so it's wonderful to have a fundraiser that knows what she's doing. So we thank you, Denise, very, very much. But anyway, so the form's there, so please let us have your recipes. We're asking the deadline to be January the 15th so that we can get this cookbook out the month of April, which is National Parkinson's Awareness Month. So we'd like to have it out by April. So that is in your packet. Also want to thank our supporters and the pharmaceutical companies. Without them, we could not hold a conference this large. We have close to 300 people, so that's a lot of getting registrations done, and the drug companies and the supporters are wonderful. So I would like to give them a hand, and they've got exhibitors out here, so thank you so much. Are there any questions before I get started, before we have our first speaker? Have I answered everything so far? Well, we're so glad you're here, and we welcome you. And if you have any questions, please just see one of us. I'm going to ask Susan Dietrich to come up from the Information and Referral Center in Charlottesville to introduce our first speaker. Thank you.
Good morning. I can't tell you how gratifying it is to see so many people here. I'm pretty excited about it. We all are. We sort of feel like it's a family reunion in a lot of ways. So if it's your first one, you have to come back next year because we can really welcome you then. I am Susan Dietrich, coordinator of the American Parkinson Disease Association Information and Referral Center of Virginia, and I kind of expand that into a little bit of West Virginia and North Carolina as well. So if you're here from those states, thank you and welcome. Dr. Wooten, our first presenter, is a professor of neurology at the University of Virginia Health System. I wanted to tell you that in 1994, a meeting was held in Charlottesville with Dr. Wooten, Miriam Hirsch, and members of the APDA in Staten Island, New York, which is the headquarters. And that resulted in the establishment of the APDA Information and Referral Center in Charlottesville. Miriam was the first coordinator. Dr. Wooten is the medical director, and he is also the APDA Scientific chairman of the APDA Scientific Advisory Board. We rely on Dr. Wooten to give us the most up-to-date understanding of Parkinson's disease, so I turn the program over to him.
Can't hop up on the stage quite as fast as I used to be able to. Sorry. I would also like to echo my gratitude to Kathy, Lynn, Andrea, especially Miriam, and my partner in Charlottesville, Susan Dietrich, for all that they've done to make this meeting happen. You know, no one who has Parkinson's disease asked for it. We didn't order this from Sears Roebuck, and given that we didn't ask for it, there are gracious few things, but there are some things that we as physicians and you as patients have under our control that makes life better with Parkinson's disease. And one of those is to know as much as you possibly can about the disease, about the treatments, about the research, about the symptoms, and I don't think there's any question that the educated patient and the educated caregiver do better with this disease than people who are afraid to learn and engage the issues of the disease. And so I would guess that if we took a population of patients and caregivers who are here today and a control population that have never come to these meetings, you would definitely see a difference in the quality of life and outcomes of people who seek education and seek knowledge. Are you hearing me okay back in the back? I have a tendency to mumble. Okay, good. So in the last few sessions that I've done at this meeting, we've talked a lot about therapy, medical therapy. And I thought it was appropriate this year, because of all the progress that's been made in the last half decade and understanding more about the disease process of Parkinson's disease, to kind of ask the question and try to answer the question of where and when does Parkinson's disease start. It's been an article of faith for 40 years that the more we know about the mechanisms that cause selected nerve cells to die in Parkinson's disease, the more likely we are to develop therapies that will be more effective than the therapies that we have today. The disease process, and thinking about it conceptually in the simplest form, there is something that causes selected nerve cells to get diseased and die. And understanding what that process is that causes certain nerve cells to die prematurely, and in the case of Parkinson's disease, the dopamine nerve cells, which are so intimately causally related to the development of tremor and stiffness and slowness. Now, just as a first cut here at thinking about where and when Parkinson's disease starts, we know that even today, as Miriam Hirsch pointed out in her talk earlier this morning, we still use the same criteria for diagnosing Parkinson's disease that James Parkinson outlined in an essay in the early part of the 19th century. And that's kind of appalling, really, that I can't do any better in diagnosing a patient with Parkinson's disease than using the criteria that were defined in the early part of the 19th century, in the early 1800s. And so what we call Parkinson's disease is defined and diagnosed by the presence of the cardinal symptoms of tremor and stiffness in the muscles, rigidity in the muscles, and slowness. Okay? Now, we've known for about 40 years that these symptoms are related to and caused by a reduction in brain dopamine in the basal ganglia. That's a necessary and sufficient condition for the emergence of stiffness and slowness and tremor. And what's also been known for almost 50 years is that the dopamine concentration in the brain has to go down to about 30% of control before these symptoms appear. And the number of nerve cells in the substantia nigra where the cells are that make dopamine have to be reduced by at least 60%. So that there's a process that must go on for some significant period of time as the nerve cells that make dopamine start to die. That goes on for some significant period of time before the emergence of the symptoms. And it has to become pretty severe before there's any evidence of tremor and stiffness and slowness. So right from the get-go, we know that Parkinson's disease doesn't start when tremor and stiffness and slowness appear. It started already before then. The process has. And I think that in recent years we've learned a lot more about what some of the signals are about when it starts. Whoop, wrong glasses. Sorry, guys. So a couple of supplementary facts before we start getting into the substance of the argument here. Again, as Miriam pointed out earlier in her talk to the new patients, there are two diagnostic criteria that pathologists use to diagnose Parkinson's when they look at a brain of a patient who had Parkinson's disease. One is the reduction in the number of dopamine nerve cells, and the other is the presence, when they look under the microscope at cells, the presence of these little markers called Lewy bodies, which are round, very concentric, round blobs that exist in the cytoplasm of cells. That is, not in the nucleus, but in the material outside of the nucleus, but inside the cell. And they have certain staining characteristics that are very characteristic. And these two findings, the reduction in dopamine nerve cells and the presence of the Lewy bodies in surviving cells, are the diagnostic criteria for Parkinson's disease at pathology. And what's come to be found about Lewy bodies, it's interesting that we'll come back to repeatedly as we think about where the disease starts and what the process is, that a certain percentage of folks who don't have the symptoms of Parkinson's disease, who don't have tremor and stiffness and slowness, who die of other causes like heart disease or cancer or stroke, some of them have Lewy bodies in their brains. And in the outline, I enumerated the most recent findings. Patients dying between the ages of 50 and 59 who don't have Parkinson's disease, about 2% of them have Lewy bodies that are called incidental Lewy bodies because they don't have symptoms of Parkinson's. Patients dying in the decade of age 60 to 69 have almost 5% of them have Lewy bodies, but they don't have Parkinson's disease. And dying between the ages of 70 and 79, almost 10%. And then folks dying between the ages of 80 and 89 have between 10 and 15% of them have Lewy bodies. So there's a population of folks out there who don't have tremor and stiffness and slowness, but who do have Lewy bodies. And we assume that those patients or that those folks are at risk if they live long enough or if they have certain exposures that may hasten the process, will ultimately develop Parkinson's disease. So this is an at-risk population that accumulates Lewy bodies as we age. Okay? Another datum that I want to kind of get on the table as we consider the evidence about when and where Parkinson starts is that we've come to realize as the life expectancy and quality of life of patients with Parkinson's has improved with the use of levodopa and Mirapex and ropinirole, Requip, and deep brain stimulation surgery, that there are some late complications of Parkinson's disease that are not treatable by any of the therapies that we have, either the medical therapies or the surgical therapies. And these include freezing and falling and loss of postural reflexes, and depression and cognitive problems with processing of reasoning and so forth. And these and this really underscores that as the disease process progresses and Lewy bodies affect more and more parts of the brain, that there are signs and symptoms that are part of the cluster. Not everyone gets them, but many do. And this is part of the spectrum of Parkinson's disease, and it further indicates that many of these consequences are not due to just involvement of dopamine neurons, but other nerve cells as the disease progresses in its later stages, other nerve cells that control balance and control emotions and control cognitive function may be affected also. So this is a clue that's come clearly in recent decades that the disease process is not restricted to dopamine neurons, but as it progresses, higher levels of the nervous system may be involved. And as we talked about last year in talking about levodopa-phobia, it's not that levodopa and Mirapex and Requip stop working as time goes by. It's just that other symptoms develop that are not responsive to these medications. The tremor, the stiffness, and the slowness do continue to respond. Now, one of the most I think clarifying and important sets of observations that we've had in the past 10 or 12 years has come from a neuropathology team in Germany, the BRAAK, B-R-A-A-K, a husband and wife neuropathology team, who have studied Lewy bodies and the principal constituent of Lewy bodies, that's a protein called alpha-synuclein. And one of the first observations that the BRAAKs made was that they had the opportunity to study the brains of several patients who had very early Parkinson's disease, but who died of other causes. So they didn't have advanced Parkinson's. It was very subtle and very early. And somewhat to their surprise, they found that there was extensive Lewy body pathology In other words, these Lewy bodies that we find in the substantia nigra in patients who die of Parkinson's disease, there were extensive Lewy bodies present in nerve cells in the ganglia of the heart, of the colon and stomach and esophagus, of the olfactory epithelium where we sense olfactory or aromas or smells, and also a number of brainstem nuclei at the base of the brain, even further down than the substantia nigra. There were many nuclei that had Lewy bodies in them, implying that there was an ascending process of pathology that may even start in nerves in the periphery, in the gut, in the heart, perhaps in the skin because of sweat abnormalities, certainly at the end organ of sense of smell, and then subsequently in these lower nuclei in the brainstem. And this gave rise to a staging scheme that the Bracks developed that would indicate that Parkinson starts kind of peripherally and ascends in the nervous system as manifested by the progression of the distribution of Lewy bodies as Parkinson's disease progresses. Okay? This then serves to further underscore that the Lewy body disease process must be going on for a significant period of time before it ascends up to the level where the substantia nigra is, where the process, when it is advanced far enough, will produce a sufficient reduction in dopamine that tremor and stiffness and slowness start to appear. So that sub rosa, unknown to the patient, unknown to their families, unknown to the doctors, there's a process going on that is relatively subtle, but we'll see in a minute it's not that subtle, before the development of the characteristic features that we use to diagnose Parkinson's disease. Now, what have we learned in doing epidemiologic studies in the past mainly 10 years about evidence that in fact the Brack theory of ascending pathology in fact really does occur? Are there any supporting criteria? And I think that probably the most powerful evidence has to do with the GI tract function. And the first important study that had a bearing on this was a study done by some epidemiologists working with a database of all the men in the Hawaiian Islands who were put into a health database back in the 1970s and then followed. And it's a very rigorous, vigorous, detailed database. It was so detailed that they were actually recording the number of bowel movements per day that the patients had. I mean, it was really detailed. And the bottom line is that when they looked at the data in the last 5 or so years, and they looked at the patients who had looked at folks who had developed Parkinson's and those who hadn't developed Parkinson's, and they looked back at all the variables that they had measured and followed, that lo and behold, if one of the men back in the 1970s averaged less than 1 bowel movement a day, he was like 7 times more likely to develop Parkinson's disease than a man who averaged 2 bowel movements per day. And this finding then has been pursued further, and it's very clear that decreased GI function, constipation, slow GI transit time, difficulty swallowing, top to bottom, that in a large majority of patients who developed tremor and stiffness and slowness, there was a period sometime in the past, perhaps 5 years earlier, perhaps 30 years earlier in some cases, where there was a clear development of slower GI function many years before the symptoms that we call Parkinson's disease emerge. Okay? So that's one set of data. Another set of data is the evidence that the innervation, the heart gets nerves to it. It gets sympathetic and parasympathetic nerves that control how fast the heart beats and how vigorously the heart beats. And it's become clear that the nerves that go to the heart from peripheral ganglia are affected, or quite affected, by the time there's the first appearance of tremor and stiffness and slowness. Now, fortunately, that doesn't cause much dysfunction. The heart does pretty well without its innervation, interestingly enough. But what does occur when these autonomic nerves are affected early is labile blood pressure, where blood pressure is very difficult to control. It may be high, it may be low, it responds in an unusual manner sometimes to antihypertensive medications, and also sweating control becomes a problem. And I know that we're vexed by many patients with Parkinson's who have developed tremor and stiffness and slowness, who also develop these involuntary bouts of intense sweating that go along with gastrointestinal dysfunction and poor blood pressure control, or labile blood pressure control. So the autonomic nervous control, not only of the GI tract, but also of blood vessels and the heart and the sweat glands, are clearly affected prior to the development of tremor and stiffness and slowness. Okay? Another feature that we had just, I've been taking care of patients with Parkinson's disease since the early 1970s, and it had just never struck me until some studies were done of the sense of smell in patients with Parkinson's disease. It is very unusual for someone who has developed tremor and stiffness and slowness not to have a measurable defect in their sense of smell. And many times our patients are not aware of that. They're just not aware of it. Some certainly are, and some can actually tell you when it changed. But a very high proportion of patients who develop the symptoms of motor dysfunction of tremor, stiffness, and slowness have lost their sense of smell previously. So as part of this ascending Lewy body process. Another data set has to do with sleep disorders. The most characteristic disorder of sleep that seems to predict risk for Parkinson's disease is something called dream enactment behavior, or REM sleep behavior disorder. This is a really interesting phenomenon. When people who don't have Parkinson's disease fall asleep, they go through different stages of sleep until they get to what's called REM sleep, rapid eye movement sleep. And if you've noticed your kids or your dog when they're asleep and they have these episodes of rapid eye movements, you can see the eyes moving, and there may be jerks and twitches and little vocalizations that occur. And that's when you dream. That's when these funny eye movements start, involuntary eye movements. You're deeply asleep, but dreaming. And one of the characteristics in people who don't have Parkinson's disease is that our bodies become very limp during that time. And if we're measuring the electromyogram, everything goes limp except the eye movements and the dreaming. But for some reason, patients with Parkinson's disease don't go limp. And so many of them have this condition called rapid eye movement sleep disorder, where they basically act out their dreams. And if they're dreaming something funny, they'll laugh. And if they're being threatened in their dreams, they'll fight back or run or jump out of bed and knock over the bedside table. And many spouses of patients with Parkinson's disease wake up in the morning with black eyes and bruises from acting out the dreams. And again, this is clearly related to the involvement of some of the lower brainstem nuclei, where this ascending Lewy body process has affected some of the deep brainstem nuclei that control sleep and control the reflexes associated with sleep. And so there's a lot of evidence that the process that ultimately affects the substantia nigra, the dopamine neurons, and causes tremor and stiffness and slowness, the process starts way before then and can produce GI dysfunction, dysfunction in smell, sense of smell, problems with blood pressure control and sweating control, and sleep problems, most especially REM sleep behavior disorder. And there's recent evidence that, particularly with REM sleep behavior disorder, that it may start to appear as long as 30 or 40 years before tremor and stiffness and slowness. So in some patients, the harbingers of Parkinson's disease may occur decades before the symptoms actually occur, and yet we're just not aware of any emerging difficulty with motor function. Now, how do we put this in context of thinking about the disease? We, just as a default position now, we think about Parkinson's disease that the risk is a synthesis or integration of some genetic or inherent risk factors and environmental factors that could range all the way from the kind of water you drink to chemical exposures to general anesthetics to head trauma to God knows what else. But these kinds of experiential extrinsic factors that may influence age of onset or even risk. Now let's just think about what the implications of that are. We know now that there are about 15 different gene mutations of different proteins that can lead to death of dopamine neurons and tremor and stiffness and slowness that look like Parkinson's disease, that are either dominant or recessive characteristics, where basically anyone who inherits the gene has a high likelihood of expressing the disease as they reach their 50s or 60s or 70s. But they're very rare. They're extremely rare, and probably there are very few people in this room who have Parkinson's disease who have that form. Only about somewhere in the 8 to 10% range of folks with Parkinson's have affected first-degree relatives such as parents or siblings. But in the patients who do have these dominant or recessive forms, their disease, it must start at conception because the genetic defect is there as soon as the egg and the sperm get together. And so whatever the process is that somehow picks out the dopamine neurons and these other neurons in the brainstem can start in them right from conception, literally. And yet it only causes the symptoms that we recognize as Parkinson's 50 or 60 years later. This long dormancy period. Okay. The incidental Lewy body story that I talked about earlier, where there are a percentage of patients of folks who die of causes unrelated to Parkinson's disease and who don't have Parkinson's but who do have Lewy bodies, suggests there's a spectrum of suggestions there. One may be that folks who have an inherent predisposition to Parkinson's and who are starting to develop Lewy bodies but haven't developed Parkinson's disease may either be more susceptible than average, and therefore if they have an exposure which adds to their genetic susceptibility, they may be more likely to develop Parkinson's due to an exposure in the environment than somebody who doesn't have incidental Lewy body disease and doesn't have an intrinsic risk for developing it based on their inheritance. And then kind of in between there, you've got a group of you've got folks who have varying degrees of intrinsic risk based on their inheritance, based on their genetic composition, and you've got a range of different environmental exposures, and there's just a tremendous amount of chance involved. And that's what we see with the epidemiology. I mean, most patients with Parkinson's don't have any affected relatives. About 85% in our population, in our database, don't have an affected parent or sibling or aunt or uncle or grandparent. It's isolated. And in all the case-controlled studies where we've taken groups of patients with Parkinson's disease and age and sex-matched controls who don't have Parkinson's disease and look to see about environmental exposures to pesticides, herbicides, well water, head trauma, etc., there's nothing that clusters as a common, frequent, highly predictable exposure that leads to Parkinson's disease. So there must be a tremendous amount of chance involved in getting the intrinsic risk based on genetic composition with the right environmental exposure that can cause it. So it's a as I mentioned, nobody asked for this, and it's almost like the dice rolling and saying it's going to be you, and it's not going to be you, and it's going to be you, as to getting these intrinsic risk factors together with the environment. So where are we now with research priorities, research goals, recognizing that that the disease process starts many years before the bradykinesia and tremor and rigidity start. And what with these new insights that have come from studying the disease, what emerges as the major questions that we need to address and the major goals of research? Well, the obvious one, it's perfectly obvious to everyone in the room, is that we need to be able to identify people who are at high risk for Parkinson's in the premotor or pre-symptomatic period. We need to know who is more likely to get tremor and stiffness and bradykinesia later before it develops. And we know a little bit now about how to pick out who's at risk later. We know if there's a family history of Parkinson's that if you're a 30-year-old who's perfectly healthy, if you have a family history of Parkinson's, it increases your risk some, not a lot, but some. If you develop constipation or GI dysfunction, that probably increases your risk some, statistically speaking. If you lose your sense of smell, if you develop REM sleep behavior disorder. So we can start to put together these multifactorial risk calculations based on symptoms. But that's going to be far from highly valuable and of high predictive value. But at least it's a start in thinking about ultimately how to structure studies. If we can predict who is at higher risk for developing Parkinson's, to apply treatments that may slow the rate of the disease down. Okay. And I think probably the research direction, the research area that has gotten the greatest amount of new attention and intense support, both at the NIH and from private funding agencies, is the recognition that we really need some accurate biomarkers of this disease so that we aren't left with just studying whether the treatments that we have affect tremor and stiffness and slowness. That's all we have. That's all we can do to measure the disease progression. And if you remember back to the studies with Eldepril and Depronil years ago, back in the early 90s, the excitement that, boy, I shared when we found that in a double-blind placebo-controlled study that patients taking Depronil didn't develop symptoms at the same rate as people who were taking placebo. And we thought, oh boy, we've finally got something that slows the rate of progression of Parkinson's. But unfortunately, Depronil has a symptomatic effect on tremor and stiffness and slowness. It actually makes dopamine hang around longer. And so what we were seeing was basically the same thing we would have seen if we'd started the patients on levodopa. Their symptoms got better for a while. It wasn't that we were affecting the rate of progression of the disease. We had a very imperfect endpoint that we were measuring that fooled us because it's the only endpoint, it's the only way we can measure progression of disease is to measure the symptoms. So we need a biomarker. And just to drive home what I mean by this, let's take the example of diabetes. We diagnose diabetes by having an abnormal glucose tolerance curve. where if you take a load of glucose, your blood levels go up and they stay up too long. So that's an objective, measurable chemical manifestation of insulin intolerance or insulin failure and diabetes. And we can measure how effective our treatment for diabetes is, whether it be diet or oral medications or insulin, by what the blood level of glucose is. We don't have to ask the patient how they feel. We don't have to look at the complications of diabetes in terms of renal dysfunction and strokes and ocular problems and so forth. We can measure the glucose, and that tells us exactly how effective the medications are. And we don't have anything like that with Parkinson's disease. So we need an objective biomarker that will both allow, that will be an indication that Parkinson's disease risk is there, and that biomarker can be modified by treatments to really have a tool that will complement observing how the patient is doing. And I hope that the glucose example clarifies what we mean by biomarkers. But there's a tremendous amount of research now being funded and done to try to find an objective biomarker, whether it's a gene or some kind of chemical consequence of too much synuclein being deposited in the brain, or whether it's a consequence of not enough dopamine. Lots of ideas and lots of work being done. Another area that we're well on our way with characterizing these rare dominant and recessive forms of Parkinson's is to continue to increase our knowledge of what the genetic risk factors are. And just last week, a phenomenal paper was published in which literally millions of little segments of DNA were sequenced in patients with Parkinson's and compared to controls. And it showed that the rate of translation of DNA to RNA to protein was selectively increased in a certain group of genes that were focused on maintaining mitochondrial function and maintaining oxidative stress, really pointing to a commonality of a process rather than a specific gene. It's the kind of thing that may well be operative in many patients with Parkinson's who don't have a single gene that increases their risk, but a population of genes, all of which may be slightly modified to increase the risk. So continuing to search for changes in DNA sequences in key protein that encode key proteins are areas that will be very fruitful in terms of future research, so that we can understand better what these inherent risk factors are. And by knowing what these inherent risk factors are, we may be able to then tailor medications that will minimize the consequences of whatever goes wrong when this cluster of genetic risk factors are present. And similarly, if we can understand the significance of environmental risk factors. It's an entire institute at the NIH now that is devoted to trying to understand what risk factors present in the environment or present in the experience or extrinsic risk factors may modify risk and may add together with genetic risk factors to either make the age of onset earlier or to actually increase the risk for Parkinson's disease at all. And if we can identify these, then obviously there can be lifestyle modifications and perhaps even after the fact treatments that can minimize the consequences. So these are all areas of research where we're really getting right down to the basic issues of what the process is that causes dopamine nerve cells and other nerve cells to die. And it's been informed by understanding much more about what Parkinson's disease is, how it starts, how it progresses, and how the nerve cells die. Now, in conclusion, the common factor in all of the in all of the various processes that lead to Parkinson's disease still is, just as James Parkinson's essay pointed out back in the early part of the 19th century, the common feature is death of dopamine nerve cells. It's not the first thing that happens, but it's the characteristic, it's what unifies this. And you know, we now know with the rare genetic forms of Parkinson's, of which there are about 15 different mutations of different proteins, that there's a great deal of diversity of the function of these different proteins, that when there's a mutation and the protein doesn't work normally, it causes dopamine nerve cells to die. And that's pretty amazing. Some of the mutations are of genes that encode proteins that affect mitochondrial function, either structure or function. There are other mutations in this 15 of genes that encode proteins that are involved with identifying old, worn-out proteins in the cells and reprocessing them back into their constituent parts so that they can be reused. These misfolded, aged proteins, if you will, in cells. Completely different process from the structure of the mitochondria, yet the bottom line is that these very disparate functional proteins have in common that they kill dopamine neurons. So that insight, I think, focuses still on what is it about these dopamine neurons that makes them susceptible to such different kinds of insults. And that also is an area where there are many new insights emerging, one of which hopefully will be the key to how to protect these cells. So I think that especially in the last 10 years, the seeds have been sown to really understand mechanistically at the molecular level what causes this disease process. And I think that on the one hand, it's a little discouraging that it's so complicated. But on the other hand, it's incredibly exciting and hopeful that these insights have emerged. And I just am very excited about the possibility of ultimately having really rational therapies that will get at the disease process itself that's causing these nerve cells to die. So I thank you for your attention and look forward to the rest of the day.